Are we recording now, Kathy? Just
Yeah, it just
Okay.
happened. Thank you.
awesome. Okay, well, maybe for the sake of time, we can get started. I know others will probably be coming in as we go, but this is recorded, so really it's our tremendous honor to have Matthew Churpek present as part of the Practical Platform webinar series on clinical trials. Matt is a leader, a pioneer, and innovator in this field of moving from estimates of average treatment effect in a trial to individualized treatment effects. And as clinicians and investigators, this is a huge priority for all of us, to have more precise estimates of how treatments affect our patients. So Matt, thank you so much for your willingness to do this, and let me hand it over to you to take it from here.
Great. Thanks again for inviting me and for the kind introduction. And can everyone see my screen?
Yes.
Great. All right. So just briefly with disclosures, I do have grant and research support, some of which relates to some of the topics I'm going to talk about today. I'm also a named inventor on a patent for a machine learning algorithm that's an early warning score to identify critical illness, but that's outside the scope of the talk. And the learning objectives for today are to discuss and learn the advantages and disadvantages of different methods for identifying heterogeneity of treatment effects in clinical trials, to understand how machine learning can be used to predict individualized treatment effects, increase the awareness of recent applications of machine learning approaches for ITE and critical care, and then learn important future directions of research in this area. So I think many of us have probably heard this, this phrase that critical care is the graveyard for clinical trials. And in fact, if you look at most of the trials that have been published over the years in critical care, we often hear that they are quote unquote negative trials. And I think this paper nicely summarized the fact that currently there's no conclusive evidence of any pharmacologic intervention that has consistently reduced mortality in critically ill patients. When you look at clinical trials, what we're often doing then is we are presenting the average treatment effect, which is the average treatment summed across all participants in the trial. However, I think clinically we have this intuition and this idea that the benefit and harm for interventions that we are providing for our patients likely can vary across patients based on their own individual characteristics. So we think about what we're discussing with our patients at the bedside. Often what our patients want to know is which treatment does the evidence say will produce the best outcome for me, right, for the patient in front of you. But us as clinicians, if we're looking at the literature, we're often saying things like, well, the evidence from the randomized controlled trials show the best treatment overall on average for patients is, but then of course the patient is saying, well, that's not what I asked. I want to know what's actually the best treatment for me based on my own individual characteristics. So what clinicians and patients want really is evidence-based medicine, but also personalized medicine. In other words, doctor, what treatment does the evidence say will produce the best outcome for me? And so if we take what we're seeing in results of randomized clinical trials, we're often seeing, again, this average treatment effect. Here you see the treatment effect along the x-axis with the number of patients in the study on the y-axis. And instead of presenting just this average treatment effect, what we want to determine is, well, let's look at the individuals in this study, and can we determine which patients may have benefited from that treatment and which may have harmed. And even though the average treatment effect may not be significant, the individual treatment effects for every patient in the study, for some of them at least, it could be significant, and some may be benefiting or being harmed by the intervention. And so this concept is known as heterogeneity of treatment effect. And so what are the different methods then we can use to identify factors such as age or comorbidities, et cetera, that are associated with HTE? So there are many different approaches that have been used over the years for identifying heterogeneity of treatment effect. Subgroup analysis, I think, is the most, the most familiar, certainly to us, and the most commonly used. Over the last several years, there have been increasing studies looking at unsupervised clustering methods to identify subtypes or subphenotypes or phenotypes, depending on what study you read. There's also this idea that you can look at the risk of the outcome. For example, stratifying patients based on Apache or SOFA, and maybe sicker patients are benefiting or being harmed by the therapy, and less sick patients have a different experience. And then finally, what I'm going to focus most of the talk today on is this idea of developing models for individualized treatment effects. In other words, predicting for each individual what their benefit or harm may be. So first, for subgroup analysis, the idea is that if you take these treatment effects across all the individuals in the study, you essentially start looking at one variable at a time. In other words, you can look at older versus younger patients, women versus men, et cetera, and seeing whether those are the factors that are associated with the heterogeneity of treatment effect. Unfortunately, we've seen many instances where this can go awry. This is there's been many studies now that have looked at zodiac signs. This one relates to cardiovascular outcomes based on your zodiac sign. And you can see that, unfortunately, if you're Capricorn, you may not want to be drinking as much at your parties because you're at increased risk of adverse cardiovascular outcomes. And again, you see this time and time again where subgroup analyses, because you're doing so many of them, you can lead to these answers that are, clinically probably not accurate unless you're an astrologist. So of course, I think the pros are that if you already have strong a priori knowledge of some variables that may be treatment effect modifiers, it can be useful. It's also, I think at first glance, it's easily to interpret and understandable by clinicians, and of course, is something we're familiar with. But there are, of course, disadvantages. One is the fact that it's underpowered because you're looking at each of the different subgroups. Again, if you are testing multiple subgroups or even including things like zodiac signs, you're going to have false discovery. And I think the other thing as it relates to applying this to the bedside, you're only looking at one variable at a time. And of course, our patients are multidimensional. So a patient might fall under a category that suggests benefit, but then they may fall under another subgroup that suggests harm. And it becomes complicated then to actually apply this to your patients. An emerging field over the last several years, which has been spearheaded by Carolyn Kelfi and Pratik Sinha and colleagues, among others, has been this idea of clustering using unsupervised methods to identify subphenotypes. So this idea is that if you have this heterogeneous population, you could then group these patients into similar clusters that have similar characteristics. For example, similar vital signs, similar laboratory values. And then you can look at whether these different clusters have varying experiences with mortality, and also whether they have different treatment effects. So if you look back at the diagram, then the idea would be, well, let's see, maybe cluster 1 is the group that has a benefit and cluster 2 is being harmed by the therapy. So there are some advantages to this approach. It can potentially, I think an important advantage is it could potentially discover underlying biological important and distinct patient subgroups. It also does consider multiple variables at a time, so you can identify for each individual which subgroup they belong to. However, because you're essentially creating these larger subgroups of patients, the individual treatment effects could vary within a subgroup. In other words, maybe overall cluster 1 benefits from the therapy, but the cluster 1 could still include some patients who may be harmed by the therapy. In addition, our group in collaboration with Pratik Sinha and others have shown that there are many different clustering methods, and then the different groups that you create from these clustering methods can differ based on the approach that you're using. And then finally, because these are unsupervised approaches, they actually aren't directly trying to model for treatment heterogeneity. In other words, they're trying to identify groups that are similar, but that may or may not relate to whether the patients are benefiting or being harmed by the therapy. And so the next set of approaches are related to trying to use supervised statistical models, in other words, models where you know the outcome in the training data to develop approaches to identify heterogeneity of treatment effect. Recently, there have been several statements and guidelines published around this. I think the one that we often refer to is called the PATH guidelines. And so if you want to read more about these approaches, this is a nice summary statement about this. There also is a related statement in terms of how can we identify heterogeneity of treatment effect in observational healthcare databases as well. So in the PATH statement, they separate into a couple model types. So the first model type are called risk models. So these are models that can predict the study outcome. And essentially, in other words, if, for example, the study outcome is mortality, you can use something like the Apache score, or the SOPA score, and then you can stratify your patients based on that model for HTE evaluation. For risk models, you could either use an existing model. In other words, if you're collecting the Apache score in your trial, you can then use that score in the trial, or you could develop your own risk model, taking the baseline characteristics to predict the outcome of the study, and then use that model developed in the trial. With outcome risk modeling, essentially what you're doing, again, going back to the original diagram, is that you're imagining maybe less sick patients are benefiting from the drug and sicker patients are being harmed, or vice versa. Essentially, you're trying to see if you're using the risk of the outcome as the stratification variable for these, as opposed to with subgroup analyses where you're using many other variables. A nice paper on this topic was published now 10 years ago by Jack Washington and colleagues, where you can see on the top graph mortality along the y-axis, and then the x-axis is the deciles of baseline risk of death at randomization. And at the lower graph, you can see that the idea here is that in this example, for the patients at a lower risk of mortality, the intervention favors the control patients. And for patients at a higher risk of mortality, the patients with the intervention actually do better. And again, this relationship could be reversed, but in general, you're using the outcome risk model for your stratification. So there are several advantages to this approach. So one is that there are, as we know in critical care, many scores that are already available, and often trials are collecting things like either SOFA or Apache score. And also, if you think about, there may be some interventions that come with side effects that are important. And so maybe the risk of the side effects, if that is somewhat stable across risk of mortality, but the benefit of the outcome increases as mortality risk goes up, then this could be a reasonable hypothesis in an intervention like that. However, there are important disadvantages as well. I think one is that the outcome risk model needs to perform well in the current study. In other words, you may have an Apache score and the outcome may be mortality, but if you find that Apache doesn't actually predict mortality very well in your study, it's not going to be a very good tool for this type of HTE analysis. In addition, it may be that the risk of the outcome may not be even related to benefit or harm from the therapy, or it may be only weakly related to the benefit or harm from a therapy. And so in those cases, it may not perform as well as other approaches. So finally, in the types of methods that I want to focus the rest of the talk on are these models called, what the PATH statement calls effect models. So what effect models do is it predicts individualized treatment effects by including the treatment variable and the outcome in the model when you're developing this approach. So what is the individualized treatment effect? So the individualized treatment effect is the difference in the outcome, the predicted outcome, with different treatments for individuals with the same baseline characteristics. It's sometimes called conditional average treatment effect. There's a field in marketing called uplift modeling that includes this. There actually, if you look in the literature, there's many different names for this. The difference in the definitions that can sometimes be subtle, but again, it's important to know that this is something that is seen in a lot of other fields. For example, my brother actually does marketing, and they use these types of methods. And the idea is, if you can only send out 1,000 flyers, you want to send to get your company more money, more donations. You only want to send those flyers to people who are going to donate because they received the flyer. So the idea is very similar here. There are a number of different methods for these effect models. Some of you may have heard of things like causal forests or random forests. So random forests are a popular approach for predicting an outcome. Causal forests are related to random forests, but they're predicting essentially this individualized treatment effect. And so there are many, many approaches that are available. I'm going to give you one example to try to solidify what these models are actually doing. So there's an approach called a T-learner, and what T-learner means, it just means two models. The T is for two models. So the idea is, in this approach, you take the patients in your treated group and you build a model. And that model, what it's doing is just trying to predict the outcome. So let's say you're doing aspirin versus placebo. So you take all the patients in the aspirin group and you try to predict mortality or whatever the outcome is. So that's model one. You then take all the patients in the control group, in this case, the placebo group, and develop a second model, again, to predict the outcome of mortality. And now, when you have a new patient you want to apply this approach to, what you do is you take, for that new patient, using their baseline characteristics, you output the prediction for model one, which is what would be the mortality prediction if they got aspirin. And model two would give you the mortality prediction if they received placebo, and then you subtract those two. In other words, if you have a new patient who walks through the door and the aspirin model says they would have a 10% mortality if you gave them aspirin, and the placebo model said that they would have a 20% mortality if you gave them placebo, the individualized treatment effect prediction then is they would have a 10% absolute benefit of mortality if you gave them aspirin. And that's essentially what these approaches are doing. They're providing individualized absolute benefit or harm from an intervention. And even though these are fancy machine learning models and there are many, many approaches out there, essentially this is how they work. So in other words, what you're doing then is you're taking here with the different patients in your training data, you're taking the treatment variable, which is the first column here. You're taking the baseline variables in the study collected in the trial. And then you're also including the outcome, whether the patients survived or not. And then for every new patient, you're taking their baseline characteristics, and then you're basically contrasting the prediction if they were assigned the treatment one versus if they were assigned treatment two or placebo, and then outputting that predicted treatment effect. And ultimately, you can take a randomized controlled trial, and for every patient in the trial, you can get an individualized treatment effect of their degree or benefit or harm from these models. So these approaches have several advantages. One is, I think an important one is certainly they can predict these numerical treatment effects. In other words, you're not just getting assigned a group one or group two, you actually get an individualized prediction. And so you can actually incorporate these models in along with things like cost effectiveness analysis or patient care decision making, looking at side effects, et cetera, to make individualized treatment decisions. They also consider multiple variables at the same time. However, these models can be complex. These models are typically complex and can be difficult to interpret. So you need to use explainability approaches to understand why your patient is getting a prediction of either benefit or harm. And these models are also prone to overfitting. In other words, this idea that the models will fit both the signal and the noise in the data. So you really need an external data set to validate that the models are working well. So there have been a number of high-profile applications in critical care, one led by Ewan, looking at the heterogeneous treatment effect of therapeutic dose heparin in patients hospitalized with COVID-19. I think it was an outstanding paper that actually looks at subgroup analysis, outcome risk modeling, and effect modeling in the same paper. So I think this is a great one to read if you want to look at how the contrasting results look for these different approaches. And then one published that our group published last year on individualized treatment effects for oxygen targets, which I'm going to discuss more in the following few minutes. So as an example for how we can use these models for critical care, if you look at oxygen therapy in the ICU, We know that if you provide lower levels of oxygen and target lower oxygen saturations, the concern we always have is, well, you worry about things like hypoxemia and tissue hypoxia. However, if you provide higher levels of oxygen, the concern there is maybe you're causing oxidative damage and inflammation and other side effects. And so there have been many randomized controlled trials comparing a low oxygen target versus a high oxygen saturation or PaO2 target. And these studies, which have been done across the world, have found no significant difference in the average treatment effect. So what we wanted to do was we wanted to see, well, even though there's no difference in the average treatment effect, could there have been patients who benefited and other patients who were harmed by these targets? And so what we did was we developed an individualized treatment effect model in the pilot trial and then separated by time and space, because these are performed in different time periods as well as in different continents. We validated our model in the IC Rocks trial. So when we developed our model and we looked at the predictions of individualized treatment effect, which are shown here along the y-axis, and then we ranked the patients by their predictions along the x-axis, we found that there are some patients who were predicted, as you can see on the far left here, there was a patient with a 27% decrease in absolute mortality with a lower SpO2 based on the model predictions. And there was a patient on the far right who was predicted to have a 34% decrease in absolute mortality with a higher SpO2 target. What we did with these different thirds of either benefit from a lower target, no predicted difference, in a higher predicted target, we wanted to understand who these patients were. And what we found was those patients who were predicted to benefit from a lower SpO2 target were older. They also had higher rates of acute non-hypoxic and hypoxic brain injury. Those patients predicted to benefit from a higher SpO2 target had higher rates of respiratory disease, sepsis, and also higher values of their vital signs as well. The next thing we wanted to do was to see, well, we looked at the predictions, how did the patients actually do in these different subgroups? And what we found was the groups that were predicted to benefit from a lower target did actually benefit from a lower target. And those here you can see in the red, who we were predicted to benefit from a higher SpO2 target, did in fact benefit from a higher SpO2 target with a significant p-value for effect modification. So ultimately, the use of an SpO2 target predicted to be best for each patient developed from a model developed in the pilot study, instead of random allocation of the SpO2 target, would have reduced the overall mortality by an absolute 6.4% in the IC Rocks validation trial. So this suggests that if we would have used this model, we could have improved outcomes in those patients, again, in this validation set. So then what's next with this, with using these types of models? So I think there are many different ways we could potentially use these models once they're validated. One approach you could use is to help assist with planning of future randomized clinical trials. For example, you could, at the interim analysis, you could potentially identify those patients who are benefiting or being harmed by the therapy and potentially make adjustments to the trial at that point. You could also use prior data and use the models to identify which patients you should enroll in the trial to try to enroll patients who are most likely to benefit from the intervention that you're studying. We are interested in trying to figure out how do we actually take these models we develop in retrospective analyses and actually get them to the bedside to see if they can improve patient care. And if you think about it, one of the ways that this is a graph that a figure that Matt Semler had created when we were trying to just figure out how to think about these different levels of validation and levels of research rigor in this field. And certainly you can do retrospective analyses of completed trials, and that's probably the first level. You can then move to prospective derivation and validation in a trial where you're actually running the model prospectively. And then finally, you could take that model, for example, the individualized treatment effect model that predicts who benefits or might be harmed by different levels of oxygen targets, and compare it, for example, to usual care to see if the model itself may be able to drive care better than what is in current practice. So related to our SpO2 target, one of the questions we had was, well, are clinicians already targeting the SpO2 that are best for current care? Because an important aspect of machine learning modeling is that, you could develop these fancy models, but if they're no better than what clinicians are already doing, then the model is not going to add any value. So the first thing we wanted to know is, are the clinicians already doing the quote unquote right thing already? And what we found is if you look at the SpO2 here along the y-axis and the FiO2 along the y-axis on the bottom graph, and the days along the x-axis, you can see that the yellow is the better outcomes with the lower SpO2 targets, and the dark brown is where the model predicts better outcomes for the higher SpO2 target. And we found that there's no significant difference between the two groups in terms of what's targeted or the amount of, and there is a slight amount of higher FiO2 delivered for the patients predicted to have a lower SpO2 target benefit. In other words, there was not, currently in clinical practice, there's not a large separation, and the clinicians are not currently doing the same thing that the model would predict. And that shouldn't be surprising, because if you look at all the different variables that are included in the model, it would be very, very challenging for a clinician to take those 24 variables, come up with the 16 million combinations, and then be able to sort of output exactly what the machine learning model is doing. So with that in mind, in a trial led by Matt Semler and the Vanderbilt group, they're currently planning a what they're calling the Express trial, which is a parallel group RCT. It'll be done in the Vanderbilt ICUs for patients receiving mechanical ventilation. And they're going to compare a personalized SpO2 target based on the machine learning model we develop. And the control group is going to be usual care, and they're going to see if the machine learning model can improve outcomes as compared to usual care in the study. In addition, we've been collaborating with Paul Young and his group, and we are currently working to get the model ready for validation in the much larger MEGAROX trial, which is similar to ICU-ROX, but much, much larger. And he's also interested in a similar interventional clinical trial comparing the model to usual care in a step wedge fashion across the ANZIX ICUs. And just as an example of where we're hoping this can go in the future, this is from a different publication from our Bougie trial, which was published in the Blue Journal a couple of years ago. The idea is that both when we're using these models, but hopefully sometime in the future for one of these models, you might see something like this in the electronic health record. Essentially, you get auto-populated values of some of the different information, and then some of it that's harder to get automatically from the EHR, you're able to input this information. And then in this trial, it was comparing intubation with a stylet versus a bougie. So you can see on the right, based on the values that you provide this interface, the model will output its prediction of which intubation approach would be have the highest likelihood of success for that patient. You can see that at the top. And at the bottom, then it's then telling you which of the variables are really driving that prediction to help you understand, well, okay, the model's saying it's, stylet is the way to go. Well, why? And for this individual patient, it's because the airway characteristics is one of the main reasons why the patient is likely to benefit from a stylet intubation. And last, an important question is, well, how can we optimize future clinical trials for ITE analysis? I think one of the things that we found really challenging is identifying trials where with the same intervention, where you could develop a model in one trial and validate it in another trial. Because I think, as I mentioned before, these models can overfit, and it's important to be able to evaluate the generalizability of these machine learning models before you would start thinking about implementing it in clinical practice. So if we can harmonize the types of data that are collected across trials, then we might be able to develop these models and validate them more easily. In addition, we found that the ability to collect more granular data. In another paper that we worked on with Pratik Sinha and colleagues was related to collecting biomarker data. And we actually found that these, if we had biomarker data available, we could actually identify HTE much more easily than without biomarker data. And we've also found with more granular EHR data, things like laboratory values, for example, can be important for HT analysis. In addition, as I mentioned before, there are many different causal machine learning methods. There's an alphabet soup of approaches one could use. And currently, we don't know what methods work best in critical care trials. So one of the studies that we're working on is trying to compare these different approaches to provide users of these methods some guidance on which approaches will work best in clinical trials. And then finally, and I think most importantly, is trying to do what we can to increase the collaboration between data scientists and trialists. I think as data scientists, we learn a lot from the trialists on how these trials are run, what they think might be most important for HTE discovery, how they might think about implementing these models after they're developed in future trials. And I think the trialists also, as the data scientists learn more and more about these methods and when they work best, could help inform the trialists on how to better improve the efficiency and effectiveness of trials that are ongoing and also future trial planning as well. So in conclusion, several methods exist for investigating HTE in clinical trials, and each have their own advantages and disadvantages. Machine learning approaches are available and can be used to directly model individualized treatment effects for characteristic specific predictions. And accurate, validated IT models could lead to more informed and personalized decisions at the bedside. I just want to acknowledge all of our collaborators in this work, and thank you all again for inviting me, and I'm happy to answer any questions that you have.
Thank you so much, Matt. That was outstanding and an incredibly accessible summary of these very complex methods. Let's open it up for questions. Question from Art.
Hi, Matthew. That was a great talk. Very clear. I even understood it, so that's fantastic. You know, you said one thing at the end. You said you're looking at trying to determine which causal methods work best in critical care trials specifically. Why do you think there should be better methods in critical care trials than oncological trials or cardiovascular trials? What's the rationale for that?
Yeah, that's a great question. So I would say that we are currently working on separately a number of studies in oncology trials. So we have amassed several dozen oncology trials, and we're comparing different approaches in those trials. I think that one of the things that can be different across the different fields one would be the outcome type. So as you know, in oncology trials, oftentimes you're looking at survival outcomes. And these methods actually, many of them have not been used in survival outcomes before. And so it's likely that new approaches are needed, or some different approaches may work better in those types of trials. And also, I think in critical care, we have other things like how large are the trials, different sizes of trials. Methods may work better in smaller trials, where other methods may work better in larger trials. So these 50,000 patient cardiovascular trials, you may find other methods work better. And then I also think that some of the maybe some of the ways some of the variables that are collected and the ways they may interact in acute illness may differ. So again, I think that ultimately our hope is to expand these approaches across many different fields. And we may find that the same methods work best in all of these different fields, but I suspect that we may find differences across the different specialties.
Thank you.
Maurizio?
Yeah, hello, Matt. It was a great talk. Matt, practically, how do you think that we will change the way we do trials? Because this is great, but at the end of the day, it's still a causal inference method. as a post-hoc analysis on something that is already being done. Do you think that we will reach the stage where we can actually stratify the randomization based on small groups of HTA, basically, type of patients? I mean, is that going to be feasible, you think, in a short period of time to reach that level?
I think the short answer is that we don't know, I would say. I think there are a number of different ways these could be used for trials. For example, it could help enrich the trial at the beginning. So you could use some of the knowledge gained from earlier retrospective trials when planning a much larger trial. For example, in Megarox, one of the things they did, because of the fact that we found certain variables were important in the causal machine learning models, they now have started to collect some of those additional variables in Megarox, which they hadn't been collecting before. So I think these models could inform what variables you collect. They could potentially inform what patients you enroll. I think it's possible they could also, maybe combine with adaptive or other types of more sophisticated designs during enrollment. But I think at this point, it's unclear how feasible those different approaches are. And I think that's why collaborating between trialists and the data scientists and these methods, trying to understand where they could be helpful, but also where they could potentially be harmful to the use of, the implementation of trials, I think is really important.
Matt, I have a question. I know you've wrestled with this a lot, but it's interesting that you and Matt Semler have decided to do a kind of validation of your really elegant oxygenation target analysis. And when I read your paper last year in JAMA, I was tempted to think, well, this is as rigorous a validation as one would ever need of HTE modeling. And yet you clearly, despite your expertise and understanding of these methods, are sufficiently skeptical that you think that another validation is needed. So maybe talk to us a little bit about how and when you think one can reach a conclusion to say, hey, we don't need any further validation. We can now implement this in practice. And obviously then there's a whole set of practice and implementation barriers that need to be addressed. But sort of what's the threshold for saying now it's time to put these things into practice?
Yeah, so that's a really great question. And I think that, as someone who does machine learning for a living, I'm always skeptical of these models because I know they can overfit the data, and they also can learn relationships that may not, that are complicated enough that you may not know when these models are going awry. So I really do believe that additional validation is always important. I think because of the fact that with the oxygen targets model, like you said, we went from we developed in one continent in one time period, and it still worked well in another continent in another time period. I think that's why we were confident enough to go to the next step, which is to see, does the model do better than usual care? I do think that that is still necessary. In some ways, I think about it similar to how we maybe think about FDA approval of, drugs. You may have great, basic science lab data that your drug works, but you do need to then test it, probably in a couple trials to show that it works better than the current standard of care. And then I think at that point, then you can move forward with implementation at the bedside, because there are also, I think there are a number of costs related to this type, using these types of models. I think certainly the cost we worry most about, of course, is that you're using the model, but it actually really doesn't work. It doesn't do anything better than usual care. So that would be cost one. But then the other costs, of course, are, well, you need to figure out how to run a machine learning model in real time at the bedside, and figure out how to get all these data elements in, and get your clinicians to use it. And that also is a actual cost and also opportunity costs. So I do think that it's really important that we move from retrospective validation to external validation to prospective validation to testing in a randomized trial versus usual care before we can move to applying it to the bedside as sort of now the new standard of care, similar to how we might do this with other drugs or other interventions in our field.
And one follow-on question. I see Art, your hand up, but one follow-on question, Matt, is do you anticipate that in your trial of model guided care versus usual care that there might be HTE?
HTE of yeah, that's sort of a rabbit hole, right? So you get HTE of the HT, right? I mean, I certainly think so. I mean, I think part of it is right with usual care there, and I think the other thing is right if the field, for example, finds that patients with hypoxic brain injury may do better with lower oxygen targets, or you read a few papers on this topic, then usual care might be to provide lower oxygen targets for that, those patients. And so what you might find is, and maybe some of what the model is doing, part of what the model is predicting, that's one of the sub cohorts that is getting that prediction of a low SpO2 target. So you might find that the model is only sort of benefiting beyond usual care for those patients who have more complex interactions of all their baseline characteristics. So absolutely, I think that certainly could be the case and something that we're trying to figure out how to tackle in the trial.
Interesting. Art.
So Matthew, I agree with you that makes sense to be conservative here. I was thinking the same thing as you, and when I read that paper, which I think was a fantastic paper. So I have two questions about it. One is, you talked about overfit. I would have thought that when you have a validation sample, that takes that into account. I mean, no matter how much you overfit, if you do it in a validation sample, separate in time and space, how does overfitting play a role there?
Yeah, so you're absolutely right. So when you have that external sample, you are accounting for the fact that you're really removing most of the concerns about overfitting. But I do think that as you sort of, I think the way we behave in clinical trials and maybe the way we treat patients, et cetera, there may be nuance. So maybe overfitting may not be the right word when you're talking about that external sample, but there may be these differences between what happens in a trial versus what happens out in the real world in terms of how we might treat these patients, where the model might learn certain associations that are true in these trials where we're watching these patients very closely. But once you just run it in the background in the EHR and have it pop up as an alert, the way we treat the patients in the real world may be different. So in some ways, it's not, it's sort of like the model may pick up on signals that are true in trials that may be not true in real world care. And I think we just need to be sort of, that may be one explanation if these models don't end up working in sort of the real world.
Yeah, the other reason I think it's worth further validation, quite frankly, is I think the results are too good to be true. Like, honestly, just all comers, you pick the saturation, the decreased mortality by 6% absolute, just seems to me implausible. I mean, I'm not saying it's not right, but it just seems implausible, quite honestly. So I'd love to see it in a prospective trial.
You're preaching to the choir on that one. When we saw those results, it really was too good. It seemed too good to be true. But I think the fact that some of the things that bore out, like the fact that hypoxemic brain injury. I mean, there are some sort of things that I think there were some hints in the literature that some of these may be biologically plausible, which may led us to say, well, we only need to like quadruple check our code and then have several people run it from the beginning to end, make sure everything looks good before we send it out there into the wild. So yeah, I agree. This is again another reason why we're validating both the model retrospectively, and we're actually we have other collaborations. We're trying to continue to do that in addition to Megarox, in addition to testing it in multiple trials and hopefully in collaboration with you as well. I know we've been talking about that work.
Yeah. Thank you.
Pratik.
Hi, Matt. Thank you. Great talk. I never fail to learn when you speak. I have a little question which I've been wrestling with in my brain about the evils of subgroup analyses versus the evils of overfitting. Now, to my mind, we have seen enough subgroup analyses to think, are they really worthwhile, even if they're described a priori? Do you think we should start moving to running these algorithms as standard post hoc after a trial to learn more from the data that we've acquired? Versus, do you think the risks of overfitting are too high and that the outputs may be equally as junky as subgroup analyses?
Yeah, that's a great question. So I do think that the nice thing about these approaches is if you separate if you have a true separation between your training data and your testing data, and you pre-specify your analyses and you look at the test data, and you only need one p-value. You'll get one p-value in your test data, which basically says, does the model order the patients from who benefits versus all the way to who is harmed better than chance? And you have one p-value, and those predictions apply to every individual. Whereas in subgroup analyses, you are, again, as we all know, right, you're getting many p-values, and of course you could adjust for multiple comparisons. But again, in addition, you are each individual patient will fall into many of the different subgroups. And so it becomes challenging again to apply these methods to an individual patient in the future. And so my hope is that in the future, more and more trials are pre-specifying these types of analyses as part of their future analysis plan in the trial. So in other words, you might still say our preclinical data or whatever, it says these are 3 or 4 really important subgroups. So sure, maybe we should still do that. But pre-specifying these methods in a trial of adequate size so that you are investigating these multidimensional models that you could actually apply to the bedside in the future, because that will, I think, will get us higher level evidence and get us closer to getting some of these models to the bedside, or at least using them for planning of future trials.
So am I hearing you correct that you're telling Ewan to start including these in his pre-specified analyses in his future trials?
I think that would be a great idea. I don't know how would you be. I guess Ewan, what are your thoughts on that? Is this something that you're, as you plan future trials, and you all from the group, I'd be interested to hear your thoughts on that as well.
Oh yeah, I would say we've really drunk the Kool-Aid, and I would think that this ought to be part of a pre-specified SAP for most trials, because it can be very informative. And I think the really exciting idea is the one that Maurizio raised, is that we would actually be using this embedded in adaptive designs to learn about HTE as the trial progresses, that we don't have to wait to the end to start identifying the treatment responsive subgroups. So a lot of work to be done, but I'm interested to hear from other trialists on the line here, but definitely in our work, we're very interested to incorporate this in a pre-specified way. Rob, I see your hand up.
Oh, thanks, Ewan, and thanks, Matthew. That was a great way to start the morning of clinical work. To Art's comments, like that, some of the effects may seem too good to be true. Like if we accept that that's possibly or probably the case for some of the patients at the extremes on either end, like, do you think, if you were going to, offer up explanations, do you think that those effects at the extremes are more likely due to, small numbers and some chance and or that there's sort of a deeper level of, residual confounding, especially when there's an interplay between physician choice and the intervention, and things that you can't know or tease out when there may be an influence that is not recorded in a CRF. And then, so those would be like, I don't know, 2 of a few different options about why there might be such big effects. And then a follow-on would be, because it seems so darn important if those effects are true, is there a value in getting into the really granular details, for instance, for say 50 or 100 patients on either extreme end, to say if these are real outliers, I wonder if we could do a study that goes back into the charts of those patients to say, okay, we know what we know from the trial, but let's actually have smart people try to tease out how on earth could we get like a 28-30% mortality lowering increase, etc., and try to think about it in almost a qualitative way at those extremes to see, we didn't account for this, or my gosh, it might be real. Thanks.
Yeah, so those are all great points, and I think, right, if you look at the model's predictions for every individual, I would imagine that those ones out at the greatest extremes. I mean, if you think about things like regression to the mean, if we were to repeat this in new patients, I would imagine that some of those effects may not be as extreme. And so, I think that could that relate to, like you said, whether it's sort of some combination of clinical factors plus then how those patients may have been treated. Could we get at more information through chart review? I think that's also possible. I think that would be. I'm not sure how challenging that would be in the ICU Rocks trial in terms of what would be allowable, but I think that is a really interesting idea to see if we can identify what are the reasons for those patients out of the extremes. I think the other piece, though, is that ultimately, at the end of the day, if we imagine these models out in the wild, you're going to have to identify what, like a decision threshold for, when are you going to say, let's give high FiO2 or, high oxygen targets, and when are you going to say, I'm going to do a low oxygen target? And so I think depending on the intervention, there may be some interventions where I really want to know if this model says 30% absolute mortality benefit. I really want to know why, and maybe that's wrong. Maybe it's actually only a 15% mortality benefit. But if both of those points lie on the side of providing that intervention, then from a decision-making standpoint, it may not change what you would do. But there may be other situations where it would, either for patients who are crossing to the other direction from you should get this treatment versus that treatment, or for interventions that may come with significant harms or side effects along with them. You may really care about that exact prediction. So I do think that some of the things that we're working on, such as trying to validate these models in a number of other trials to see if those predictions, especially how the extremes match what actually is happening, I think will be really important to validate those more extreme predictions. And in addition, I think that's a great idea of, can we go into the charts of some of these patients or try to identify what are the factors that are really driving those most extreme predictions to simultaneously say, number one, are these true predictions or not, for the best of what we can validate, and number two, why are they getting these extreme predictions? So thanks those questions and those ideas for future research that we could do.
Well, thank you so much, Matt. As you can see, there's incredible engagement and interest in the work that you're leading. And so we're incredibly grateful to you for your time, your lecture today, and look forward to seeing your future work, and want to thank everyone for joining us this morning. Thanks to Hiroki Saito, the practical education lead, for helping us organize the webinar, and also to Kathy Chow, the platform project manager, for making this all happen. So thank you everyone for your time. To those of you in the Eastern time zone or close by, have a great day. And those of you who further away, have a great evening. Thank you so much.
Thank you, Matthew.
Great. Thanks, everyone.
Thank you.
Bye-bye.
Thanks, Matthew.
Bye.